So I'll be presenting a case on lens. So this is a 65-year-old gentleman who presented with gradual onset defective vision in both eye and some glare issues. His IOP was 22 millimeters of mercury in both eye. Best corrected visual acuity was 20/80 N12 right eye, 20/60 N10 left eye. So my first question is, what is the diagnosis and what is the content of the deposited material?
Cataract with pseudoexfoliation.
So it is a case of pseudoexfoliation, and the deposits are actually elastin fibers, mainly containing fibril and alpha elastin. So the second question is, how to differentiate it from true pseudoexfoliation? So the true
In true exfoliation, you get a scroll of of the delamination of the layer of the capsule, and you don't get those fibrillar material mainly deposited at the pupillary rough. In pseudoexfoliation, you don't get that kind of a scroll, and you just get fibrillar material deposited on the pupillary rough, and that gives you an idea that.
yes, sir.
Basic is true is complete and false is incomplete.
And second,
Keep
you
in
can
mind
ask even in the history, although that is those who are working in a heat condition or oil factory,
Glass bowlers.
they having usually true, but pseudoexfoliation is not.
Third question is, name two other sites of deposition of this material and the related ocular features. So,
Trabecular meshwork.
so it can be deposited in the trabecular meshwork causing glaucoma. It can be in the sonules causing sonular weakness and dialysis. It can be in the pupillary margin causing a small and rigid pupil. And next question is the gene which is associated with pseudoexfoliation syndrome. It is the LOX L1 gene.
This is a just now they have come with one gene, and they find out this, but it is seen only in if you see the 100 cases of pseudoexfoliation, out of that they are saying that 7% of the cases may have this gene. So others is they are saying, but yes, one of the like glaucoma, there is one gene now causing the pseudoexfoliation. But what they say here also, basically it is a temperature where the patient is working, and that causes the pseudoexfoliation.
Question number 5. What are the complications that need to be expected in cataract surgery while performing such cases?
Now in such cases, the basic complication in cataract surgery is, as you to see the pseudoexfoliation, there are also the zonular weaknesses. The zonular weakness is there, non-dilating pupil is there, and in such situation, the cataract is always, you can say, the harder, because it has happened because of the, you can say, the temperature. And so because of that, what happens in such situation, it is better to go for SICS. You should not go for picomultiplication. You have written chances of IOL drop and VR surgeon nearby. It is not required if you go for the SICS. And all modern people should think on the SICS when there is a pseudoexfoliation. Another thing is, in the pseudoexfoliation, you operate the patient early where the zonules are not weak. It means if patient is having the stage 1 or stage 2 cataract, you go and operate. If the patient is coming late, then the SIC is better. Now you can use the, you can say, the pupillary, you can expanders, or also you can use the capsular support, and in that, but always better to go for the SICS, and if possible you can go with the PICO, but chances of the subluxation or dislocations are much more. And as you know, it is pseudoexfoliation. It is always end in complication. To avoid, experience will help.
So how to manage if there is intraoperative sonular dialysis?
See, the zonular dialysis is there only when there is a pseudoexfoliation and true pseudoexfoliation. If it is a not true pseudoexfoliation, then there is no zonular dialysis. In pseudoexfoliation, there is always a zonular dialysis, our weakness. Without that, there is no cataract. So if it is there, then as you see, seen this, all these rings and CTR and all other things, definitely that will help, but not in much in pseudoexfoliation. Where the other zonules are stronger, then that will help. Now what we are doing, by putting these 3-4 clock rings or all others, we are taking the support of other zonules. But here the other zonules are also weak. So it is always better that we must use the expanders like that, remove the nucleus, and this always go for CTR. Why? This CTR will support in 360 degree. CTR will be better than the local segment. So you can go for the CTR.
And what are the chances of development of glaucoma in such eyes?
See, it is said that in the pseudoexfoliation, 12% more glaucoma is developed as compared to the non-pseudoexfoliation. Secondary glaucoma chances are much more in these cases. Now here the high around 40, 45-50% chances, yes, it may be there. But in the glaucoma, if you go to the glaucoma, it is 12% pseudoexfoliation is the cause in the 100 out of 100. So in this case, yes, 45 to 50 in pseudoexfoliation cases it may be there. And here see the treatment here. As you know, the pupil is very this one, there is a pupillary block is happening, and also you can say the pseudoexfoliation also is in the angle. So in this, the trabeculectomy definitely work than any other surgery.
Thank you, Dr. Rakhi.
Thank you and congratulations. Very good questions.
Dr. Kagrata.
Very good. I think this exercise that definitely gives the insight to the student also.